And it's important to note here that the policy decisions aren't just based around cost effectiveness or models. There's a lot that goes into it. Over the last few years, I think models are becoming increasingly important to help guide policy. Next slide, please.
So this one is seen
So
from
this is a
here.
very oversimplified diagram of what a model is. We start with a real world problem, and that might be HIV incidence going up, for example. And based on our understanding of that problem, we try to express it in epidemiological terms. So we look at the probability of acquiring HIV, how it progresses over time, what happens to the population who don't have HIV concurrently. So we identify data to inform models and often have to make assumptions where that data is not reliable or doesn't exist. Then we run the model, so we may run the model with a status quo scenario and compare it with an intervention scenario. We analyse the outputs, interpret results, and help inform policy. Of course, in real life, it's not that simple. This is a very simplified diagram, but it does give you an idea of how models come to play.
I don't want to do it.
Next slide,
I
please.
don't want to do it.
So there's several well-established HIV mathematical models, modelling settings in Africa. Most of these are listed on these slides. They vary in assumptions and structures, and most models actually are calibrated to more than one setting and have extensively been used to inform policy. Next slide. Now, in recent years, as economists mentioned, we have the HIV Modelling Consortium. This is where those models that you saw on the last slide have come together as part of the consortium. So instead of one model tackling the same question, we have multiple models looking at the same question. And this is hugely beneficial because we have model outputs from an array of models with different structures and different assumptions. And if in agreement, we're able to provide very robust data to policymakers. Next slide, please. So over the last few slides, I thought I'd give you some examples of projects that the HIV Modelling Consortium have undertaken and the impact they've had on policy. Now, the first is medical mouse circumcision, and this was a project done a few years ago, so before the funding cuts. And PEPFAR approached us with this question of interest, that given the scale-up of treatment programs and the limited HIV program resources, does the provision of voluntary medical male circumcision continue to represent a cost-effective use of HIV program resources? So we had 5 modelling groups tackle the same question, and they all looked at 2 scenarios. No further VMC in any age group, and continuation of VMC for the next 5 years. Next slide, please. And this is what we found. So we looked at 3 settings, Malawi, South Africa, and Zimbabwe. And in Malawi, all models were in agreement that continuation of VMC continues to represent a cost-saving approach according to all models. In Zimbabwe, a continuation of VMC was cost-effective and cost-saving according to one model, but not quite to the other. And the other thing we were able to show with these analyses was that VMC cost-effectiveness depends on HIV incidence. So it was cost-effective in 62% of settings where HIV incidence was less than 0.1
So Christopher, you are seeing from here.
But in 95% of settings where HIV incidence greater than 1.
Yeah.
So as well as publishing the paper with those results, we were able to provide a guidance to PEPFAR, and our results featured in their COP22. And along with other evidence, we were able to contribute to the continuation of VMC funding over the foreseeable future. And so that's really an example of how modelling directly influences policy. Next slide, please. Sorry, next slide again. Next slide. The second example is about analyses that took place during the COVID pandemic. As you all, I'm sure, well remember, it was a time of great uncertainty, and we wanted to be able to advise policymakers what services to keep going in a time when there were global lockdowns going on. So the question that we were interested in was, what are the potential effects of disruptions to provision of HIV services due to COVID-19 on HIV-related deaths and new infections? Again, we had several models looking at the same question, and they all considered potential disruption to HIV prevention, testing, and main results like from the paper? And I know you might be able to see it very well, but it looks at the relative change in mortality across the bottom and the disruption to services across the left-hand side. So we've got disruption to BMC, condom availability interrupted, suspension of HIV testing, and so forth. But the key message to take away from this slide is that all models agreed that disruption to ART services had the biggest impact on mortality, and we were able to provide very clear evidence to policymakers. And that's quoted directly from the paper that during the COVID-19 pandemic, the primary priority for governments, donors, suppliers, and communities should focus on maintaining uninterrupted supply of ART drugs. The next slide, please. So just a few final notes. As you've seen on those slides, modelling can directly influence policy, and the use of multiple models particularly strengthens the reliability of these findings considerably. It allows models to evaluate their own and other models, and particularly the underlying assumption of those models. And this is considerably more time-consuming than any single model analysis, but that's balanced by the robustness you get at the end. And often models may not be aligned perfectly, so as modelers, I think we've come to manage our expectations and really focus on the interpretation of those results. So it's important to interpret outputs with an understanding of the context under which they were generated, so having some idea of model limitations. Thank you.
Thank you so much, Lovely, for such an elaborate presentation about modeling. And I'm sure those that are not in modeling have managed to catch one or two things from your presentation. Just to inform you that we managed to get a scene online, and she's going to talk about how she uses her health economics and in collaboration with the modelers to make decisions for governments. Yasin, can you hear me? Are you able to connect here?
Yes, I can hear you. Thank you. I'm trying to share my second. Okay. I hope you can see my screen. Good morning, good afternoon. I'm quite saddened that I can't be there with you. Can someone confirm that you see the appropriate display?
I think they're trying to change over.
Can you hear me?
So just speaking on to what Lovely was talking about, she talked about multiple model comparisons, and that is some of the work that you do. As she indicated, models, they do have different assumptions, but for the models that you currently have, you find that if you run some simulations, we do not agree 100%, but you find that all our trends will be sort of following the same shape. So at the end of the day, we are actually able to make some conclusions from what the models are giving us, even if they've got some different assumptions. Are you winning? Or should we go to the next presenter?
Next.
The next one. Should we take the next presenter?
Yes.
Okay. Our next presenter is Dr. Mkurugi. I wanted us to talk about the health economics before we go to actual implementation, but anyway, we are going to look at how people are using the model results that we are generating to inform their policies. Over to you.
Thank you so much. Good afternoon, ladies and gentlemen. My slides are coming through. My name is Owen Guru. I'm the Director for AIDS and TB programs within the Ministry of Health and Child Care from the Republic of Zimbabwe. I'll just share some practical experiences that we have had with modeling. Let me start by saying that our national context, modeling has become an integral and important part of our work because it allows us to use tools that are critical for us in setting our priorities, our targets, and monitoring tool of our work. Next slide, please. Can I have the next slide? Yeah, so I was saying that models are important for us in setting priorities, targets, and optimizing the use of available and limited resources. They are also important for us in defining trends, patterns, and measuring progress towards our national strategic plans. We use them as very important resource mobilization tools, and of course, to assist us in reporting to our funders and also globally to the UN states towards progress towards engagement. And yeah, of course, very important and make sure that we change policies. Next slide. Here I'm trying to show where we have used models. Of course, I'm not a health economist, but in essence, taking from the health economics, we can be able to calculate the values and also say what is the most effective intervention that we need. And you see that in terms of HIV, near programming, you see sex work, index testing, self-testing, pre-exposure prophylaxis are very important interventions that we use when it comes to HIV prevention. And as we go down, you see that there is less cost effectiveness because it's incremental cost. But this is important for us to make sure that we introduce and scale up the interventions in terms of limited resources that we have. Next slide. Another example in voluntary medical male circumcision, they also assisted us in Zimbabwe in particular. We are now know that based on our epidemiological control, we now know that because we introduced VMMCs, we were able to prevent more than 100,000 HIV infections over the past 10 years. And this becomes a very important analysis tool because we're able to show and get our partners and donors to say this is what we've saved and this is what we've dedicated and this is where we are because of the UMC. And you can also see that we did very well in trying to make sure that we have less HIV infections in the settings that potentially would have been used for HIV treatment. And next slide. In today's world, we know that we don't have all resources, but we still remain focused on trying to get our targets of ending AIDS by 2030. And again, we've been told to reprioritize, relook at what we are doing, and try and see where you can have cuts and where you can integrate. This you will also see that this is a modeling example where we say if we maintain the status quo of the interventions that we have, Zimbabwe will not get to ending HIV by 2030, will actually get there in 2041. But if we then introduce long-acting pre-exposure prophylaxis together with index testing and differentiated services, we can actually get there. another example, this is one that I was talking about, in terms of monitoring the progress towards AIDS, seeing where we are. You can see that by 2020, yes, we were
Because they are really
targets that we set in terms of reduction of HIV infections, but still using what see that we would not get the required numbers that we needed to be in 2020. So again, it emphasizes that we need to be done with better
like
to make sure that our
eyes for me.
programs are another example. So just well, I think that one having already talked about use of the MMC. This one now, we are now in an era where this is after UST cuts funding to most of our programs, and then we also wanted to know what would be the impact. So we see that if we continue with the funding, we would have continued with decrease in HIV infections. But the cuts, because they happened, there will be an increase in HIV infections. And our incidence, which was 0.87, actually 0.87 within 1 year, if the cuts
So I'm
continue
coming
to be permanent.
they can hear this one by
And
ear.
if the cuts were permanent, then nothing is done, we would actually go to an incidence of 1.55. So it's a very important tool for us to mobilize resources and to remind our governments and partners that we still need to do next. Next slide. Is that the first one? Okay. The last one is, of course, it is already talked about VMMC, the work that we did in the Modelling Consortium in terms of VMMC, because people thought, well, we are done with set targets for VMMC. But this really showed us that despite the fact that we had achieved the number of circumcisions that we required, we still needed VMMC to be part of that comprehensive package so that we can maintain the gains and also continue to decrease the number of infections. That's all I have for you in terms of practical examples. So thank you very much.
Thank you so much, Dr. Mkureli, for sharing some examples from Zimbabwe and how you have used the modeling. I think we are running out of time, so I'm going to hand over to Prof. Mulinga, who is the director of the HIV program in Zambia. And if you can be a bit fast, Prof, I would really appreciate that.
Thank you so much. I think for me, what my brother from Zimbabwe, Dr. Mkureli, has highlighted is just what I would like to just emphasize. During this time when we have had changes to our funding landscape, that's when I've seen more utility of data coming out from modeling. When we were asked to reprioritize our interventions, first from the Global Fund, but also from our government as well, we needed to have evidence on how we're prioritizing some of the services. And really, that data-driven framework is needed for someone to come up with these and during this time, we were looked at various organizations that needed to exactly organization we needed to invest more in. and accessing relevant data. And like several institutions that invest in mental health systems, was involved high compared to other interventions as well. So we had to use modeling data. And we used that as well in coming up with our HIV basic minimum service package. So we had to again see which interventions can we do. Like when we had to look at the testing, when we started PrEP, we started using the NAT testing, the new date-based testing for injectable PrEP. But again, with the changes in the funding landscape, also this switch come as well, and the data which we use, we found that there was no utility for us moving in that way. So again, those are things which we had to implement, especially with the changes in the funding landscape as well. But also, it's not that just the medications which are effective in this model of data. It's quantifying the outcomes across, which rarely our programs under this
Make I tell her, let me tell her the sound is coming.
but with the modeling, we were able to
Where is she?
advise policymakers on what cost-effective interventions we need to invest in and what the outcomes as well. And that has led for us to have optimal resource allocation. I know it's not easy, especially that we have to do some sensitivity analysis when we looked at our HIV basic minimum package and also our introduction of men as well. We have to see how much would it cost for us to invest in community programs compared to us investing in facility-based programs, and looked at the outcomes, how many HIV infections we are going to abate, and also if we are not investing in each of those, how many we are going to get HIV, and what will be the cost of maintaining someone on treatment as well. So those sensitivity analysis, they made us come to the conclusion that possibly this is what we get, but that is model data. And right now we are moving into our where over the next few years we will be analyzing outcomes depending on the interventions which we are providing in the different areas in the country. Some facility-based, others community-based, and look at all those outcomes. And possibly now we have new data coming from the program on the cost effectiveness of delivering of these services. So this is how modeling has helped us, and we intend to use it in many, many areas.
Thank you so much, Professor Mlenga, for giving us some experience for exam here. We are now going to quickly move on to the funders. Yes, we have here for us talking about funding. So now we need to know how the modeling work is informing the decisions that they make in terms of which programs to fund.
No, no, we're here.
Funding the
Sound for pick the audio.
of HIV TB
That is the
delivery
problem now.
Bill and Melinda Gates Foundation.
She go come, she go talk, but then we don't go hear what she dey talk. We dey here, we go hear. But then they no go hear.
Thanks very much, Adina. Good afternoon, everyone.
Sorry,
The Gates Foundation is both a funder
Oh my God, Moro go fit carry something.
and also
Something so come.
uses modeling to decide what we prioritize. So, as I'm sure many of you know, Bill has decided that the foundation will sunset in 2045 and is giving $200 billion to cover that 20-year period. So all of the program support teams of the foundation, including the one that I lead on TB and HIV delivery, have to present to Bill and the leadership every October on new strategies, new strategic plans. And this October, we were asked to think about what it is that we would be funding, should be funding, could fund over the next 20 years, and what would that do? And in my case, specifically for TB and HIV, on reducing incidence and reducing mortality. So those are the questions we were asked to model. So we, of course, tried to model and anticipating the pipeline on R&D, because the assumption being that fidelity could really bring down the incidence of mortality. And of course, the second part of it is how do we use existing tools more effectively, more efficiently. So we did all that, and then presented, of course, to Bill. Of course, it was built on a large number of assumptions. Now, what all these good people didn't tell you yet is that sometimes models can get it very wrong. So we also need, and you saw that during COVID, there were multiple models during COVID, and some of the models got it very wrong. So modeling is not, it's an art as much as it's a science, which means that we have to also think about what else we can do to get our estimates or predictions or conclusions somewhat more accurate. So, and I'm saying this because as a user, as a foundation and I are users of modeling outputs, we've got to think about them rather rationally. At every occasion when we present during the strategic planning sessions with Bill, we have to do two things. We've got to model, and we've got to show the ICASA incremental cost effectiveness ratios to show that what we are suggesting to the leadership in terms of how the foundation should use its dollars will give us the best possible. So we don't only fund modeling exercises for countries that need it to make decisions. We also use models to determine our priorities and what we will fund as a foundation. So the environment in which we are currently in is, as has been said multiple times already in this conference, highly constrained with respect to not only the finances, but also in terms of human resources. So we need to think about these things. At the same time, it's very exciting that we have new developments of tools. So talking about TB for a minute, there's some very exciting news on the TB